Good morning. Thank you for being with us here on this Monday morning. My name is Katie Earle, and I'm the coordinator of our University Express program. And we're joined here virtually with Dr. Reed and Dr. Flores, both from Roswell Park. Thank you, ladies, for being here.
Thank you for having us.
It's our pleasure.
Of course. So as they go through their presentations, feel free to type in any questions and comments you have in our Q&A, and we'll try to answer them right at the end of the presentation, and we'll get through as many as we have in the time that we have today. So I will introduce our speakers, and I will start with Dr. Flores, and then I'll go to Dr. Reed. Dr. Flores is the Medical Director of Cancer Screening and Survivorship and an Assistant Professor of Oncology at the Roswell Park Comprehensive Cancer Center Department of Medicine. She is a board-certified internist and pediatrician. Prior to working at Roswell Park, she practiced primary care in private practice, university teaching, and community healthcare settings. She's passionate about preventative care, wellness, cancer screening, and cancer survivorship. Next, we have Dr. Reed. Dr. Reed is the Chief of Cancer Screening, Survivorship, and Mentorship at Roswell Park Comprehensive Cancer Center and a key member of the Roswell Park team that is collaborating with Cuban scientists on the SIMA vaccine. She is also currently a professor of oncology in the Department of Medicine. She's also developing a comprehensive survivorship clinical and outreach program, and they're both here with us this morning. Dr. Reed, I'll first turn it over to you. Thank you both for being here.
Yeah, again, thank you for the invitation. And I'm going to start off by just giving some basic comments about survivorship and helping to define what it is. And then I'll pass the torch over to Tisa, and she'll give much more detail on some of the issues related to survivorship. We both consider, survivorship as being sort of what life is like after cancer treatment. But the National Cancer Institute really defines survivorship as anyone who is alive after the diagnosis through the end of life. Survivorship period from when you begin treatment till when you complete treatment and then you go on to sort of regain your life covers a lot of physical consequences of treatment, psychological stressors that accompanying having had a very serious disease, challenges with finances, and really a forced redefinition of what normal life is like. And to varying degrees based on your treatment and your disease, but we really see that after cancer treatment is over, it's complicated, and we want to talk about that. So what does it mean to us? For us, we are looking at the period after cancer treatment has been completed. And it's when you're really starting to recover, when you're not spending all your time going to appointments and working your life around the side effects from treatment. And it's trying to get on with things, maybe going back to work, starting to do some more things with friends, but when your whole life is not just built around the treatment. So why are we talking about it? Well, we know in New York State there are over 1 million survivors, and that number is growing across the country, which is great because we know that with improved treatments, people are living longer after cancer treatment is over. 45,000 live in Erie County alone, and in Western New York, 128,000. And so there's really a lot of survivors in our midst. And I don't really know who's signed up for this workshop, whether you have had cancer, but most likely all of us know someone who has had cancer and survived from it. We know that the 20%, 1/5 of new cancers come from people who have a history of cancer. And again, this just tells us the impact both of treatment and the numbers of people around us who are impacted by cancer. So why again are we talking about it? Because cancer treatment does not leave you the same ever. And unlike some other diseases where You can have your appendix out, or even, you're treated for blood pressure. You have a heart attack. So many aspects of your life go back to normal. With cancer, it is not the same. We're not trying to beat high blood pressure. We treat it. Partly because of the heaviness of the consequences of failure of treatment, but really, it changes your life. And because treatment is so different from one cancer to the next and one person to the next, it can mean very many different things to your treatment. It can change how it can change your life if you've had your part of your colon resected, or you've had a mastectomy, or you've had other issues. So it's really personalized, and how you responded is personalized. And the health that you had coming into treatment definitely affects the quality or the level of health you have as you complete treatment. And cancer is not just affecting the person. It affects your whole family. It affects your friends and your caregivers, who help to get you through treatment. But they also are there for you when treatment is over, to help you get back to redefining what your life is like after cancer treatment. So the philosophy that we have at our program at Roswell is that we really focus on supporting the patient and the family. We're looking at the whole person, not just the tumor site, but the whole person. How is the dynamic changed? If you had young kids, how were they affected by the cancer that you may have had? How does it affect your work? So we're really focused on the entire person and not just where their cancer was. And again, this is an individual disease. You get grouped into, oh, I had breast cancer or prostate cancer, but really treatment and your response to treatment and how it affects your life is really individualized. And we like to focus on that. We also put a lot of emphasis on maximizing the health that you have as you are in your survivorship time. So we want to help our survivors get to their healthiest, get to their highest level of wellness. And that we support through education, through experiences, through innovative therapies, support groups. So it's really to maximize health as you go forward after cancer. And, improving the quality of life for survivors and their support networks is really the most important thing. Again, all of the residual effects from treatment, and it's not just physical, but the emotional effects we really want to work on so that you go forward in your rehabilitation and your level of wellness with the best quality of life that you can have. So one of the things that we do is we provide patients with a care plan, and it doesn't have to be from us, but we feel that there are certain things you need to know going forward, and that your primary care physician needs to know going forward, so that you can anticipate any problems and that you kind of know what happened. And so we provide every patient with a document that says when you were treated. And, I speak for, as a caregiver of someone who survived a stage 4 appendiceal cancer that happened 6 years ago. And, it was a really crazy period. And it's hard for us to realize that it was 6 years ago. So if you think 20 years later, when were you treated with this? When were you, well, it's hard to remember. So when you were treated, it's important that you know going forward that you have a summary of what treatments you got, what surgery you had, how much radiation you had, what kind of therapy, whether it's chemotherapy or immunotherapy, going forward. Again, it's not the easiest thing to remember when you're in the midst of it. So it helps to have that written down. The names of your treatment team. You think, I'm never going to forget that surgeon who saved my life. But after many years, you may forget them, or you may forget the name of the medical oncologist. And so it's important, again, to have that documented. What are the possible side effects from treatment? What can you anticipate that might come up because you were treated? And Tisa is definitely going to talk more about that in her presentation. What ongoing medications, such as hormones, that you may be taking. And, again, and we'll, Dr. Flores will also speak more about this, but what kind of testing do you need going forward? How often do you get your CT? It's more in the beginning, and it may go to annual imaging, and then that may stop after a certain number of years. What kind of cancer screening do you have? And for our program in particular, we really focus on the support services that you may need. What you need as you finish treatment is different than what you need 10 years later. But the more support you get, especially in those initial periods, will help you to be healthier and more in control of your life when you get 10 and 15 years out. We do an emphasis on genetic testing because the cancer you may have may be related genetically and can affect your family and your children. And also, we like to talk about what can be done by your primary care provider as opposed to always having things done by the oncology group. The important thing for us going forward is that your oncologist and your primary care physician need to communicate. And they need to communicate about you because you're the important person in the middle of all of this. They need to be able to tell them all of that information about cancer treatment, and the primary care provider needs to be able to ask the oncologist questions. And Dr. Flores will talk a little bit more about that. But as things come up, we want to make sure that they have a good communication pathway so that you can communicate both with them. Because if there are symptoms of some sort of toxicity related to your treatment, you can bring that up and it can be addressed in a proactive way. The other part of it is that, there are support services in your community, not just, around your oncologist, but actually where you live, that are important to identify to support you as you rehabilitate from cancer treatment. And other providers such as gastroenterologists or cardiologists in your community. So you're not always traveling, to one place, but hopefully you can find those closer to home. So, then it saves you time, but it also gives you support where you live. And we think that is extremely important as we go forward and develop our program across multiple sites on the Roswell Care Network. So again, our program is structured looking at screening, looking at our clinical team, support services, and then integrative therapies. And Dr. Flores is also going to give some information about that. But we think that this provides a very comprehensive view of support services. And this is just a list of things, support services that we're getting access to for everything from physical therapy and lymphedema and rehab and nutrition support, pain control. It's a pretty long list. These are all related to some of the effects that we see in our patients. Restorative dermatology. We've just started a sexual health program where we have one for men and for women because, again, there are consequences to cancer treatment. And we really are doing a lot with wellness and integrative medicine. We think things like acupuncture and yoga are exceptionally good therapies that can help you to focus in on areas where you may have pain or persistent nausea or a lot of physical symptoms in terms of muscles and flexibility. The other area, and Dr. Flores will talk more about that, is cancer screening. And, again, it's really important to get back on that, those screening schedules that we know pick up cancers early. There are a lot of consequences from both chemotherapy, immunotherapy, and radiation on dental. So you need to have your mouth screened. by a dentist to see if there's any impact on your gums, but also if there's any impact on any other lesions that can form. And so without much more ado, I'm going to pass the torch over to Dr. Flores. And again, thank you very much for the invitation.
Thank you, Dr. Reed, for that very, very good introduction. You do such a better job than I do with that. Katie, can I start to share my slides?
You should be ready.
Excellent. And you all can hear me? Okay. So without further ado, let's talk a little bit about cancer survivorship again. Okay. So the reason why we're talking today, oh, am I good, Katie?
If you just want to swap presenter mode and display settings, we'll be good.
Okay. Uh-oh. Let's see. We're good?
Perfect.
So there are about 17 million cancer survivors in the United States. That's about 5% of the population as of January of 2019. There are 67 survivors that have survived over 5 years, 45% over 10 years, and in the next decade, there'll be over 5 year survivors will be about 15.1 million. Nearly 2/3 of survivors are age 65 years and older. Most survivors are older adults. 64% of breast cancer survivors are age 65 and older. That's about 2.4 million people. And 76% of colorectal cancer survivors are age 65 and older. That's about 1.2 million people. Majority of the prostate cancer, about 82%, are over 65. And about 50% of melanoma survivors are 65 and older. So in your age population, there is a considerable people who are survivors. So physical concerns of survivors, 59% complain of fatigue, 55% complain of concentration issues like memory, brain, 46% complain of sexual functioning issues, 42% complain about neuropathy or pain, and 34% complain about pain. So neuropathy is nerve pain, and then 34% of the pain is just regular muscle joint pain. There are also a heavy burden of emotional concerns of cancer survivors, 80% of fear of recurrence. You know, when is that shoe going to drop? Am I going to get another cancer? Is that cancer going to come back? 68% feel grief, the fact that their life is no longer what it was before cancer, how it's affected their loved ones, how it's affecting the relationship with others. 62% are concerned about personal appearance. Anyone who's ever had surgery would know, like if it's a lumpectomy, your breasts are different. If you had a colectomy and you have a bag, that also affects the appearance. 51% are sad and depressed. Just the heavy burden of the cancer journey, and 51% are concerned about risk to family members. You know, how is this burden affecting family members? Does their cancer diagnosis would it increase their risk of their family members having cancer also? So how do you keep healthy as a survivor? And one of the first things, if you see me in survivorship clinic, is I will ask who your primary care doctor is, because it's really important that you reestablish your care with your primary care doctor. I know there's a certain time when you get diagnosed and treated with cancer, that is your all-encompassing thought. But once you become a survivor, a long-term survivor, that we ask you to go back to your primary care doctor, because the longer that you survive from your cancer diagnosis, the more likely you will have other medical issues, and it will not be cancer that will be our main concern. They can also help with other cancer screenings, manage chronic diseases, and monitor for late effects of cancer treatments. So chronic diseases, we all know this, we hear it, we see it on the news: high blood pressure, hypertension, diabetes or sugar, high cholesterol or hyperlipidemia, weight issues, whether it's underweight, overweight, or obese, hyperlipid, oh, I did hyperlipidemia twice, I apologize, asthma, COPD, and heart disease, whether or not it's coronary artery disease or if you actually had a heart attack. So we'll do a head to toe for minor late effects. So if you see me in clinic for your survivorship, I do a comprehensive physical exam, and it's usually a head to toe. So we will take a look in your mouth to see if you have a dry mouth, because this would also increase your frequent dental exams. Also, if you have radiation or certain medications can also give you bone loss in your jaw. Cataracts. So if I shine a light in your eye and I see the clouding of your cataracts, then I would recommend, when's the last time you saw an eye doctor? You may want to see them, because your cataracts might be ripe, as they call it. Hearing loss, our chemo medications actually, there are certain, they are well known to cause hearing loss. Also, as you age, you tend to also start to lose your hearing because the bones in your ears aren't as mobile. So we can actually do a hearing screen. Thyroid dysfunction. So if you get any sort of form of radiation around here, your thyroid can be affected. So we palpate the thyroid. If we feel anything like nodules or one side of the thyroid being bigger than the other, we'll get imaging and blood work. This is also something your primary care doctor can do. Evaluation of carotid artery disease. Most of you will probably have had your doctors put their stethoscope and listen here. And what we're doing there is that we're listening for bruits, because that is also a side effect of radiation. And we should have a low index of suspicion of any new symptoms. So if there are any stroke-like symptoms, we need to think that this person had radiation that could affect the carotids. Heart dysfunction, if you happen to have chemo that gives you heart dysfunction or radiation to your chest or your breast, we can get an echo, and there should be a low index of suspicion to get a stress test. Basically saying, for women, we get this idea because we are women, we are less likely to have heart attacks. But, as we age and with our cancer treatments, it does increase our risk. So the low index of suspicion for the primary care doctors to think this person could be having heart issues. Lung fibrosis, pneumonitis, secondary lung cancers. I mean, with our radiation and our chemo treatments, this is a concern. Pulmonary function tests, or pulse ox. So initially it's a pulse ox in our clinic, and that just actually tells us how well your oxygen is carried to your body and its organs. Pulmonary function test to see if there's any issues, whether there's restrictive or obstructive disease, and if indicated, a low dose CT to screen you for lung cancer. And I'll get into that in a later slide. There is an increased risk of colon cancer, so we start screening at an early age for survivors who received abdominal or pelvic radiation. Kidney dysfunction, a lot of our chemo agents can go through the kidneys, and also if there is pelvic or abdominal radiation. So we recommend getting urinalysis and renal function tests, and that's for anyone who's interested, the BUN, the creatinine, and the EGFR on your blood work. Liver dysfunction, we also know that chemotherapy and radiation affects your liver, so we ask your primary care doctor to obtain liver function tests. For CNS, that's a central nervous system, you can have neuropathy. We talked a little bit about the nerve pain. There's a lot of chemo agents that give you nerve pain. If you happen to have radiation to your brain, then there is a low index of suspicion for brain imaging. So basically, concerns of, is there a secondary cancer from your radiation? And that would be sort of anything that's like a stroke-like symptoms, or if you have a new onset headache that wakes you up in the middle of the night, or worsening headaches. Muscle weakness, we recommend physical therapy and exercise program. Lymphedema, which can caused by when we remove lymph nodes or radiation. Avascular necrosis, that happens if we give you a lot of high-dose steroids. Also, if there is radiation to certain parts of your bones, and then osteoporosis. Radiation can lead to bone loss, and a lot of the hormone therapy that we give for breast lead to bone loss. And the big one, the mental health. We always talk about physical things, but we also know that cancer has a mental and emotional toll. So there's the fatigue, the anxiety, and depression. Most of your primary care doctors should be asking you a very 2.2 question to screen you for depression. Basically, do you have any depressive symptoms, and do you have thoughts of suicide? Then we recommend an annual skin exam just to see if there's any changes in your skin that received radiation. By the time you're 40, you should not get any new moles. Any new moles is a concern for a melanoma. A CBC to monitor secondary leukemia. A lot of our agents increases the risk for AML or CML. And a lot of our other agents increase your risk for what we call endocrine issues, diabetes, high cholesterol, thyroid problems. And the infertility and reproductive issues, I know that's not a concern for the people I'm presenting to today, but it is something that is a concern for our cancer survivors. Cancer screenings, I'll just go through. Let's talk about everyone in this age group should be, female should be screened for breast, cervical cancer. The reason why we stop screening at 65 for the women out there is that this is usually a cancer of the young and it's related to HPV exposure. And HPV exposure happens more in higher sexually active females. Colon cancer, we should all be at that. Let's talk about the lung cancer screening. So it's age 50 to 80 years old. They did just change this, and it's greater than 20 pack year and stop smoking at over 15. It's different for cancer survivors, especially if you are a head and neck survivor, and if you got radiation to your chest. Does not matter about the 15 year. You can, if you stopped 20 years ago and you smoked 20 pack years and you got radiation, we can screen you for lung cancer. And that's something that not a lot of the primary care doctors are aware of that. So if you say, hey, you know, Dr. Flores, I was on this presentation and Dr. Flores says I could be screened for lung cancer because I had breast cancer and got radiation and I smoked over a 20 pack year. So let's talk about what does 20 pack year actually mean. That's, you know, we'll break it down if you smoked for 20 years and 1 pack a day, or if you smoked 2 packs a day for 10 years. So that's, you know, we throw that lingo around, but that's what we mean by a pack year. It doesn't mean that you smoked 20 packs for a day or anything like that. Screening for subsequent cancers related to radiation treatment. I briefly touched upon this. With breast cancer, we start screening at a younger age, at 25, if they got radiation treatment. Colorectal, we start screening at 30 or 5 years after radiation. And then we just talked about the lung cancer because that's the one that's going to affect this the people on this this webinar. So patients who are a current smoker or former smoker who have more than a 20 pack year, and we start screening and stop screening at 80. So let's talk about cancer prevention, because one of the things with cancer survivors or people with cancer feels so much like they have no control of what is going on with them. And this is from the World Cancer Research Fund, or AIC, American Institute of Cancer Research. And these are their recommendations on how to decrease your risk of recurrence or cancer, prevent from cancer, or prevent getting cancer. And we'll go through each little part. So be a healthy weight. Keep your weight within the healthy range throughout life. 18.5 to 24.9 is your body mass index. The body mass index has come under fire because they question whether or not this is actually a good way to measure weight. And it actually is, unless you happen to be an athlete. And then if you tend to be an athlete, you may have a little bit more muscle mass. Avoid weight gain throughout adulthood. Be physically active. Eat a diet rich in whole grain, vegetables, fruits, and beans. Limit fast food and processed foods. Limit sugar sweetened drinks. Be physically active. 150 minutes of moderate physical activity or 75 minutes of vigorous activity a week. So moderate, you know, I'm not asking you to run a marathon, you know, walking, cycling, household chores, gardening, swimming, dancing is considered moderate exercise. So that's 30 minutes for 5 days a week. And then vigorous is running, fast swimming, fast cycling, aerobics, and team sports. Do not use supplements for cancer prevention. we just ask you to try to get your vitamin needs through diet if possible. Eat whole grains, vegetables, fruits, and beans. So consume a diet that provides at least 30 grams of fiber a day. That's a couple apples. Includes foods containing whole grains, non-starchy vegetables, fruits, and legumes. Eat a diet high in all types of plant foods, including 5 portions or servings, 15 ounces in total, a variety of non-starchy vegetables and fruits every day. It's a little easier now that we are summer in Western New York. Limit fast foods and processed foods. I know this is hard during bill season, so foods such as fast food, potato products such as chips and crisp, products made from white flour such as bread, pasta, and God bless our cheese and pepperoni pizza, cakes, pastries, biscuits, cookies, and confectionaries. Limit red and processed meats. I know this can be difficult for us in Western New York because we love our delis and our pepperoni. Limit consumption to no more than about 3 portions per week. 3 portions is about 12 to 18 ounce cook size. So it's about a deck of cards. It's not this, it's like this. And then consume very little, if any, processed meat. I will admit that I have a hard time with that also. Limit sugar-sweetened drinks. Do not consume sugar-sweetened drinks. Fruit juices should not be consumed in large quantities. Limit alcohol consumption. Another thing that's hard during bill season. For cancer prevention, it's best not to drink alcohol. If you do drink, limit to 1 serving a day. If you are a breast cancer survivor out there, we recommend no more than 3 drinks a week, and definitely for colon, esophageal, and stomach, we strongly recommend that you don't drink because it is one of the modifiable risk factors for those cancers. So recommendations for managing stress and fatigue, that not only is there physical issues, there's the emotional and mental issues that come with being a cancer survivor. So how to cope with stress, your stress, caregiver stress, scanxiety. Try one of the several coping strategies until something works, distraction, this reading, watching TV, cooking, knitting, yard work, talking with someone about how you feel, relaxation, meditation. There is a lot of apps out there on the Google and Apple and Android, Headspace, Calm. Meditation is very helpful in slowing down your thoughts. Movement such as walking, exercise, yoga. I didn't put it on here, but definitely acupuncture is helpful in coping with stress. So coping with stress, take care of yourself physically. Exercise is consistently one of the best stress management techniques in treatment for depression. I know in the beginning, if you are if your mood is down, you just really want to lay around and stay in bed. If you did like 5 minutes and then increase to 10 to 15, it really will help with your stress and depression. Emotionally, talk to other patients. There's support groups. There are many support groups out of Roswell. We also have the Cancer Coach program. Find a counselor, talk to a counselor. There's a lot of community resources out there. One of the ones that I use a lot is behavioralnet.org. Spend time with friends and family. Spiritually, engage in spiritual practices that bring comfort, whether it's prayer or meditation, or talk to a clergy member. Managing fatigue. I know it sounds sort of counterintuitive, but increase your activity. The more active you are, the more energy you will have. Ask for a nutritional consult. It'll get you an aid in getting enough calories, proteins, and nutrients. Psychosocial measures, cognitive behavioral therapy, once again, seeing a counselor, relaxation, social support, counseling, rest. Keep a log of when you are most and least tired. Exercise when you are well rested. Once again, we talked about distraction, read a book. Sleep therapy. So basically, practice good sleeping habits. Limit caffeine, keep naps short. Your body likes routines. Try to go to bed at the same time. Try to get up at the same time. And what is the future of survivorship? There's a large number of survivors. In about 2014, 73% of the survivors will be 65 years and older. So that's a hard lift for the medical community and also for the survivors in general. So we need to figure out who needs what, when, and for how long. If you are 20 years out as a breast cancer survivor or 20 years out as a stomach cancer survivor, do you still really need to see us at Roswell, or is it time that we can graduate, you to your primary care doctor. And I think with survivorship care plans and also my progress notes from my clinic to your primary care doctor is basically a roadmap of the things that they need to be looking out for. And then focus, greater understanding of the consequences of cancer and its treatment, focus on application of interventions to eliminate, reduce sequelae. If cancer survivors walked every day during their cancer treatments, will they have less physical side effects such as shortness of breath? And begin to focus on survivorship education and training. Train the primary care doctors on what to look for, and also training you, the survivor, on things that it could be a red flag symptom to address to your primary care doctor. And these are some resources. So ASCO, which is CancerNet, cancersupportcommunity.org, and cancer.org. And then once again, my favorite, the World Cancer Research Fund. And that's it, Katie.
Okay. Thank you so much. Thanks to both of you. I'm seeing a couple questions here, and some you've actually answered, which is awesome. So this first question that I'm seeing is back from the beginning for Dr. Reed, one of your slides. It's, can you explain the new cancer statistic? What does that mean?
So we, and you can hear me fine, right? Okay. So some of the treatments that you get during your cancer treatment in terms of radiation, your chemotherapy, kills cells. It's, if it's not targeted, it's going after those cells that are disrupted. We also know because of the side effects from treatment that it also kills some normal cells. And so there can be residual effects that you get from this sort of cytotoxic, these extreme treatments. And depending on where you're treated, it could put you at risk for a second cancer. The other part of it is that you survive cancer and then you get older. And we know that age is the single most, it's the biggest risk factor for cancer. So you add in this synergy between being treated with fairly toxic treatments and aging, and the combination, can promote second cancers. It's really important that as a survivor, you have this really full physical and get back on the horse for getting the cancer screenings that we know find cancers earlier. And I can tell you that it's not easy once you've survived a cancer to decide, oh, okay, now I'm going to go and screen for other cancers. We know it's difficult. And oftentimes primary care physicians find it too difficult to bring it up because you don't want to find another cancer, because cancer is a terrible experience, but the fact is that we know that your risk is increased. And it's really important that you be proactive and advocate for yourself by getting the screenings and making sure you have full physical exams.
All right. Thank you for that, Dr. Reed. This next question is, how early should family members start getting screened if breast cancer is in the family?
It depends when the family member was diagnosed. So if someone who is 65 had breast cancer, then the recommendations of 40 is appropriate. But if someone was 50, then 40. But if the person was 45, then like 10 years before. It really depends on the age of diagnosis of the cancer survivor.
So I just want to add in too, if someone in your family has a breast cancer at a very young age, in their under 40, in their 30s, that implies that there may be a genetic factor that is inherited. And so it's really important that that person with the cancer gets tested to see if they carry any mutations that have implications to their family members. And that information should be shared. And that mean people are screening earlier. But what Tisa said is important too, is that not all of these cancers, in fact, the majority, are not inherited cancers, but it may be a lifestyle. And so if my sister gets cancer at a very young age and it's not genetic, I grew up with her. So there may be implications for me. And so that's why if you have a young cancer in your family, you want to start getting screened earlier. And, to be honest, we don't know everything. So we still, even with some of these genetic tests, there are some things we pick up that we don't really know if they are important or not. And we're constantly learning about what the genetic factors are. And so, for instance, if you had a test prior to 2012, you may want to get your genetics tested again because we have a lot more information now. So it is tricky, but it's important that you talk to your physician about it, or you go to genetic counseling if you have someone in your family who has an inherited condition.
Okay, thanks, Dr. Reed. So clarifying question of my own. So genetic testing is for somebody who went through cancer and survived, but also for immediate family members, it sounds like. Both are eligible?
It depends.
Mhm.
So, I mean, someone who has breast cancer, like Dr. Reed said, if someone's young, they will automatically get genetic testing. It depends on what we call the family tree. If there are a lot of cancers or certain type of cancers on one side of the family, then we would take a look and see what type of cancers they have. So most of us know about BRCA. So we would think about breast, ovarian, or prostate on one side of the family, and then that would alert someone to get colon cancer screening, not colon cancer, genetic screening. Sorry, apologize. A little part of my brain doing something else. But in general, like Dr. Reed said, most of the cancers are not inherited. It's multifactorial. But if there is a strong family history on one side of the family, there should be questions of whether or not you should be getting genetically tested. Dr. Reed, would you like to add?
I just want to say that the majority of people who get cancer do not get genetically tested. About 30% of women who should have genetic testing get it. So, not everyone wants it. You don't want to tell your family, I carry a mutation that might affect you down the line, and that makes it difficult. But it's really important information because, again, we want, if your family needs to be screened at an earlier age, picking up cancer earlier means you have a better chance of survival. That also, BRCA also applies now to pancreatic. So we know that having a mutation that's inherited with a first degree relative who has pancreatic cancer, we've just started a really fantastic program led by Dr. Flores at Roswell to screen. Because again, pancreatic is a very, very bad cancer to get, but if you pick it up early, you can do something about it. And that's really the goal as we talk about second cancers.
Okay, awesome. Thank you both. This next question is, are families eligible for counseling throughout the process?
Most definitely. Most definitely. Because it's, the definition of cancer survivor really isn't just about the person who has the cancer, but their support, because it affects everyone that's close to the cancer survivor. So most definitely, I would actually recommend it.
And I'm not shy about it. My husband always kind of cringes when I start to talk about it, but I had to keep working. I had to keep the house running. I had to do things like I don't normally do, and it's very stressful as the provider, and it impacts your thoughts of the future and of retirement and how you deal with your kids. And so it really changes the dynamic to have cancer, have someone with cancer in your family. It's not, I think as we talk more about survivorship, we're really realizing that the whole unit and friends and your parents, they're all affected, and it's really important to talk about it, to get to join support groups. Now we have caregiver support groups. How do you manage? How do you recover from it? It takes a while. So the more you can talk about it and use support services that are available in the community, the better, because everybody in the whole unit has to start moving forward when treatment is over.
Absolutely. Thank you for that. This actually next question is about support groups. This person's wondering, are there any in-person support groups yet?
So we're about to see them again. We had a couple going over Zoom, but I think now with regulations, we're at Roswell, we're just waiting for the policies to come out. We are a state institution, so the numbers, but our expectation is that over the summer, in-person support groups should start again. They may have to be restricted in size. They may have to be held in different facilities so that you have more room for spreading out. We're hoping we can do some stuff outside because that solves a lot of problems. We also hope people are getting vaccinated, because we know for cancer survivors that's really, really important, and that their family members getting treated changes your immune system. So we really want people to be protected. But I do think over the summer we're going to start to see live events like support groups come back, which I think are really important. It's much easier, it's much better to do it with other people, in their presence than it is over Zoom. But
also, there's the Breast Cancer Network of Western New York. If you didn't want to go through Roswell, they might be able to give you support groups in your certain area, whether you live in Northtown, Southtown, or downtown.
Thank you both for that. This last question that I'm seeing here is, you mentioned the care plan. Is that something paper to keep for your personal records?
Mary, Dr. Reed, I'll field this one. Yes. So when you see us in the survivorship clinic, we actually go, the first time you see us, we'll go through your care plan. I call it the roadmap, or like cliff notes of your cancer treatment. And it'll go over like what Dr. Reed has said. And then we'll actually give you a copy of it so you can carry it with you. It'll be sent to the doctors that you want it to. And it will also be on the patient portal. So let's say you misplaced it, you can actually go on the Roswell patient portal and print it out. So yes, it is. You will have a physical copy of it, and we'll go over it with you. And you can say, no, I think the date was actually this time, and then we'll adjust.
That's awesome. Thank you. Go ahead, Dr. Reed.
I tried to send a question in, but it's not letting me. So I just want to clarify that it was to Dr. Flores, but at first you don't have to be treated at Roswell to come to our survivorship program. Can you talk about that, Dr. Flores?
For sure. You do not have to be treated at Roswell or any of the Roswell affiliate site. You can be treated in any of the community and come see me. We'll do the best we can to get your records so we can make a care plan. We'll do a comprehensive exam, recommendations on cancer screening, and then also if you need any support, help you navigate into the support services. So you do not need to be treated at Roswell to see me and my team.
That's really wonderful to know. Thank you for that. Dr. Reed, I'm glad you asked it verbally. We'll just give it a second here to see if anything else comes through. So while we're waiting, is there anything either of you would like to share with us before we close?
I wanted Dr. Flores to address one other question. So she was a primary care physician in the community prior to coming to Roswell. So if you're not getting a care plan from a program like Roswell's, can you get this information from your primary care in terms of the information or what to look out for? I mean, how do primary cares handle this if their patient is a survivor and wants information on what to look out for?
So this is the hard part. So when I was a primary care doctor, a lot of the times when I would ask, how are the cancer treatments going? The patients who were very involved in their care knew what their agents were. And then there were some patients who didn't know. Primary care doctors, since I am one, they can do my job. They just need the information. I think it is overwhelming for primary care doctors to take care of a cancer survivor if they don't know what cancer treatments they've had. I do get several survivors that were treated in Texas or treated a long time ago. We don't have their records. So when I see that patient, it's sort of like, these are the possible complications this patient can have from their treatment. And then we go off from there. I mean, it's usually with long-term survivors, like let's say it's breast cancer, we usually still get the screening mammogram, but if the unknown chemo agents, it's just a little bit more blood work. As Dr. Reed was saying, you get to a certain point, whether you're colon or lung, or you just don't get as much imaging, and we just do a lot of surveillance through what we call as clinically indicated. So if we see something on physical exam or blood work. But yeah, I mean, it can be a little terrifying as a primary care doctor not to know it. We have the information, we just need it. We just need it reinforced. I think we all know that bleomycin causes pulmonary fibrosis, and we just need to think of when we see that cancer survivor who has bleomycin, we need to think this person's complaining of shortness of breath. We need to get pulmonary function tests. Very long-winded answer that yes, they can do it. We just need the information.
So I wanted to say two things. One is that there's a lot of information on the side effects of treatment, and it changes frequently. And now we're into a whole new era of immunotherapy where many organs can be affected, and we don't exactly know the long-term consequences of all of those. And it's very hard for a primary care physician to keep up. On the other end, why isn't my oncologist talking to me about all this survivorship? And again, they're focused on curing you and getting rid of that tumor. And, so they also are not necessarily, either from a time standpoint or up on the literature of some of the long-term consequences that can come back 3 and 5 years after treatment is finished. And so that's why we really need the patient to be advocating for themselves, to raise issues that they start to have, and to talk to the oncologist and talk to the primary care. And we developed this program as sort of that intermediary so that we can help to communicate back and forth, because it's complicated. And, with every time there's a new drug, there's new long-term side effects that have to be considered. So it's important to stay informed. It's important to communicate with your providers, to get someone's attention if something seems to be bothering you, a new symptom, or if you need help in dealing with some of the stress. It's really important to get someone's attention about it and start to talk about it and get support for it.
Thanks, Dr. Reed. Dr. Flores, did you have anything to add there?
No, not at all.
Okay, wonderful.
I don't know if you can hear my dogs bark in the background, so I apologize. They're howling, actually. Fire truck just went by.
That happens, but we can definitely see the value in this program and in these connections and opening up the lines of communication. So we really appreciate you both for taking time this morning to educate us on this, and we'll continue the conversation hopefully during our fall semester. I know I wrote down a couple different potential topics, and Dr. Flores and I had talked also. So Appreciate you both, and everyone who's on. Thank you for your time, and I hope everyone enjoys the rest of their day.
Thank you very much.
Take care, everyone. Stay well.